So good afternoon. Good afternoon. It's great to see so many familiar faces, new faces, old faces. Wonderful to have you here in the Jacob School. I'm Allison Brashear. I'm the Dean of the Jacob School, Vice President for Health Sciences, and CEO and President of UBMD. And it's wonderful to have you here in our beautiful space. I'd be remiss if I didn't thank Jill Cizek and the entire team from Kaleida. Jill is as a Associate Vice President for the Health Sciences, and her role is in education and research. And again, thank you so much to Dr. Cizek for all of her hard work here. So it's my pleasure to welcome you to a really, really important and timely conversation, Connected for Change, building a population health ecosystem together with one patient record. Just let that sink in. One patient record. I'm new to Buffalo, but I know that that's a big deal. So we are all deeply committed to making sure that we're doing champion health equity outcomes. We're improving patient outcomes, and we're strengthening our health systems across Western New York. And we really want to make sure that we're improving access as well as increasing the research environment and the education environment. So today's event is the beginning of a commitment that we've had and we have reinforced to make sure that we are all working together. And that really speaks to the power of collaboration. So the implementation of EPIC, the electronic health record across our region, is just much more than just a technological feat. Yes, there will be training to the doctors in the room here, but this is really about connecting our patients across our three systems. And it's also about making sure that we're transforming the healthcare of Western New York. And transforming the healthcare of Western New York is really why we're all here. So by uniting Kaleida Health, ECMC, UBMD, and the Jacob School under one patient record, we're really knocking down silos, but we're really making sure that we're providing the very best care, and we are getting rid of what has been historically fragmented care. So as a physician who's been in 2 EPIC systems, and we have several new chairs who have also been in 2 EPIC systems, you'll begin to know that you can then have things on your phone. Everything is seamless. You can see in Care Everywhere your patient records. So no more will patients be printing their records, bringing CDs, all the things that we all do right now, let alone the physicians who have to, and the staff who have to try to find a CD player to look at that. So we're really laying the groundwork for an entirely new way that we take care of patients. This is going to empower clinicians and staff to really act on real-time data. It's going to make sure that we reduce duplication. And, to be frank, it's going to lower cost of care when that is such a critical issue in our community. So it also is a really landmark opportunity because it is an unprecedented size of a connect model where we have the 3 different organizations coming together to do this really side by side. So with that, I'm going to introduce Courtney Starnes. She's the Senior Vice President and Chief Information Officer at Kaleida Health, just a stone's throw away, and she's going to share a few words. Courtney has a distinguished career in health IT. She's had leadership at several major health systems, and she's really been involved in several different EPIC implementations in her career, and we're so pleased to have her here. Courtney?
Thank you. Good afternoon, everyone. It's also my pleasure to welcome you to this Population Health Symposium, which is a topic that I think speaks directly at the heart of our mission as healthcare providers in the community and really improving the health and well-being of Western New York. As we gather under this theme, Connected for Change, I do want to take a minute to also reflect on what this means for us as healthcare organizations. But first, I also want to thank Dean Brashear, UB, the team at UB, ECMC, and HIMSS also for helping us to put on this wonderful event as a partnership together. Connected for Change is really more than just a slogan. It is a call to action. As the Dean mentioned, it means breaking down silos between our institutions. It means connecting our data sources. It also means building trust with one another, creating a shared governance model, and ensuring that we create a shared vision for the future as a community. Most importantly, it's really about the people. So connecting the patients, the providers, the community, and the families to ensure that we really do have them at the center of everything that we do. At Kaleida, at ECMC and UB, our collective implementation of our One Epic EHR is really a cornerstone of this transformation. So for the first time, we're really bringing together and creating that longitudinal patient health record. And that single patient record helps us really to transcend care settings, transcend individual providers and time as well. This is not just a technology upgrade for us. It's really about creating a foundational shift in the way that we're coordinating care, in the way that we are preventing illness, and then how we address the social determinants that impact health. So we're really laying the groundwork for this community-wide collaboration. So we can see this collaboration coming with payers, with public health departments, with academic partners, and other health systems to really build a true population health. So this panel today brings together some visionary leaders that are really driving change across our entire region. And I am excited for the conversation we're about to have. I hope it inspires all of us to think boldly, to act collaboratively, and really be connected for change. Thank you.
So thank you, Courtney. For today's panel, we have a little bit of housekeeping. It's my privilege to share with you a little bit about everyone that we have up here sitting next to me. So first of all, we have Marjorie Quint Bouzid. She is the Executive Vice President and Chief Nurse Executive at Kaleida Health. Welcome. She has more than 2 decades of leadership in hospital systems, and she brings a really powerful voice to the conversation about equity in healthcare, and we're just really pleased to have you here today. Next, we have Kristian Feterik. He's a physician and also the Vice President and Chief Health Information Officer at Kaleida Health. He's a seasoned clinician and informatist. I didn't quite get that right. Say it again. Informaticist. And really has dedicated his career to clinical care and data-driven innovation. And so he's going to share with us the insights on the intersection of medicine, technology, and leadership. And then we have Dr. Heather Gardiner. Heather Gardiner joins us this summer as the inaugural Carl V. Granger Endowed Chair in Health Equity, and she is the newly minted Director of the Community Health Equity Research Institute at the University of Buffalo, and she's a UB grad. So she's going to have her remarks to talk about community, and she really has a deep expertise in visionary leadership about expanding equity in healthcare. And we also have Igniting Hope that starts at 8 o'clock on Saturday here at the Jacob School. So please try to also join us for that. And then we have the newest kid on the block is Dr. Asim Khan. So Dr. Khan recently joined us as the Health Sciences Chief Data and Information Officer at the University of Buffalo. And he is also the newly minted HIPAA officer at the University of Buffalo. And he also is responsible for all of the chief data information officer at UBMD. And so he also has a PhD in computer science, and he has done multiple Epic implementations at different facilities that he's been. And so we're really pleased. I think you've been here 10 days. Is that right? So yes, so the new kid on the block. We put him to work really, really quickly. So I'm going to open it up with the first question, and I think it comes to Kristian. So let's talk about silos and breaking down silos. So what are some of the biggest opportunities that you think we have in population health ecosystem across the multiple systems?
Dr. Brashear, I really want to thank for the opportunity to be here. I also want to acknowledge our very important partner, Erie County Medical Center. We would not be able to do this without their help. I think breaking down silos will come to the answer of when we are seeing patients, they are not necessarily seeing us in silos. So if we're seeing patients in acute care, post-acute care, in the clinics, specialty clinics, it's important for them, and it's humane from us, to have one record available for the clinicians who are caring for the patient. It's not an easy task because, let's face it, we are perhaps looking for market share. I'm just going to put it out there. At the same time, we cannot compete on patient safety and on outcomes. So I think that's why it's important for us to think of how we can collaborate better outside of our silos.
So that's a great point. How do you think we can navigate patients' concerns about privacy and data sharing? And because, I mentioned that the data will be shared across Care Everywhere. To a patient, that might sound scary, right? How would you suggest we begin to have those conversations?
That's an excellent question as well. And so data privacy, and we need to have the trust in the information we're seeing. We need to make sure that the information is accurate. And then we have guardrails in place of how we agree to share data between the three systems and beyond. You had mentioned Care Everywhere, and then Care Everywhere branches out to a nationwide network called Care Equality. We are looking at the implementation of TEFCA from the federal government, and that goes even beyond that. So it's important for us to be all on the same agreement of how we're sharing data outwards. And I think with help from Courtney, we actually have been looking at that as well, so we can be not just proactive, but be on the leading edge of health systems.
Excellent. So a question to the group, and it's game ball here. What does connected for change mean, do you think, in terms of the healthcare context? As we talk about that, how do we message that to the community? You want to take that?
I think so. We have to think from the patient's perspective. So the patient is in the middle of what we are trying to solve the equation for. Yeah. So I think so. Let's talk about the problem a patient might be facing if we are not connected. So think about a patient whose data is not interoperable. So they're going from one medical facility to the other medical facility. Probably they'll be carrying a bunch of a file with them with their patient records. They'll have X-rays. Going back in time. They will have a whole folder of all their stuff in it. And their X-rays are in one place, their MRI is in another place, their tests are in different place. They have a PCP that is part of Kaleida, and then they have a specialty care that is part of UBMD, and all those different scenarios. So I think so part of the communication and the communication which we do for our patients is to sell this concept to them and say, hey, now you don't have to carry all those paperworks. You don't have to carry all that information as you move from your care journey from one place to another. And as you go there, if you go and see your PCP, the PCP will have everything that you would have done in the last many weeks. Either you went outside of your network to get care from there, we'll get that information through the claims network. If you went to see a specialty care, they were outside of the network, we'll get that from one of the interoperable means that the doc just talked about, and it's all under HIPAA compliant and safe. So I think so the message will for the patients would be, from the informational perspective, your care journey is going to become way more similar, way more simpler, way more HIPAA compliant, and way more easier. And it's, just you just focus on getting your care.
Anybody else?
Sure. I think it begins with consent and being very transparent about what the benefits are, but also what the risks are and what we've done to ensure that the risks are guardrailed, so that we start really considering patients in the larger community part of the partners that we have in transforming the healthcare. So they're not just patients, they're our partners in change.
I would probably add to it,
Mhm.
if I may, that our opportunity to come together and present to our community and to the people we serve that they'll be able to view their records through one patient portal as opposed to trying to gather it through 5 different means will be potentially something that can really help our community to improve our community health as well.
So to put a finer point on it, if you have Epic, it's all on your phone on one app. And so all of those records, when you see an Epic provider, and when you are a snowbird from Buffalo going down to Florida, if you go from the Epic environment here to the Epic environment in Florida, everything is there. So I think that's one of the things that is just a value add for the patient. So, so the next question's for Marjorie. So Marjorie, we want to talk about a little bit more about the one patient record. And can you talk a little bit about, access, cost of care, and how we can maybe try to level some of the playing fields?
Sure. Thank you. So I start out with a statement or my phrase or my North Star that says, health is a tool of longevity, thus a tool for liberation, right? And that is my North Star. And I've used that my entire career in healthcare to guide that decision and how we interact as healthcare providers with our community and our partnership. Any change, and this is a significant change in healthcare in Western New York that wants to or purports to pull that together and coordinate really is basically embodying what we know as collective impact. This one patient record, a single EHR, is really formulated around the tenets of a collective impact where our healthcare providers, our health ecosystem is actually coming together with a shared vision, shared resources, looking at ways to track and monitor data with one health record so that we can make bigger, more informed decisions about how we keep our population healthy and so that they can live to their best outcome. One single EHR, and you'll hear it. We've heard it before. I've heard it a lot. Courtney does a phenomenal job of telling us that within Western New York, a small, large geographically, but in terms of population, very manageable. But we have over 13 instances of a EHR. So this bold attempt to pull that together actually, interestingly enough, can reduce costs. My personal care here, if I go to 3 different doctors, I get 3 different tests. And I say, well, wait a minute, I just had that test done. Well, they don't have access to it. And it's not fair to expect a doctor to go hunt and dig it up. And also, when you have separate or disparate EHR, you have different reference ranges. So we have to, a provider has to even rethink how they plan your care. It's difficult to personalize your care and plan your care. And so we end up overutilizing healthcare resources. Communication. We all talk about communication being key. It is, it's something as complicated as health should not be, we should not think that it's accidental that I go to a provider, the provider relies on me, asks me, what did that specialist say? Then I tell them, oh, I remember to bring my paperwork, which I don't usually remember to bring my paperwork. So then I try to regurgitate what that specialist say. My provider, my primary care cannot expect to use that to make, or should not be using that to make informed decisions. And so having one single health record across this population significantly improves communication. It improves efficiency of the provider so that they can see their patients. We know in Western New York we have a shortage of primary care. They shouldn't spend their time doing administrative tasks that can be done on one single electronic health record. Again, going back to my statement I started out, as healthcare providers, traditionally, we did not consider ourselves as really being concerned with wellness care. Well, we know that is the wave of the future. The arts, according to the CDC and studies by the American Hospital Association, um, over 60% of US adults have at least one chronic condition, and that number is expected to double. So that means that majority of us are needing ongoing health care, and how beautiful to have it in a system where everyone that touches your care, to include partners in the community that provide rehab services, that looks at provide access to food, access to exercise, physical activity. They all have access with permission and with guardrails to this information. So it just creates that ecosystem, I believe, that really starts getting us to a true intentional, targeted way where we're really working as a community to keep our population healthy, particularly those most disadvantaged.
That's an excellent comment. So how about the reliability? So, like we all know Epic, it's in 95% of health systems associated with medical schools. Is there anything that we need to do about reinforcing to the community the reliability issue?
I'll take a stab and then you could try. So reliability, not having a single EHR is what causes unreliability. As you transport data across systems, each system, they're configured differently. You have to, the mathematicians and planners and developers, they have to come up with ways, and they were intentionally done that way to keep these electronic health records proprietary. And so by coming into one system, it improves reliability of data and accuracy. You're not transferring information. So if you think of the old way where we use paper, every time you transcribe, you increase your chances of error. So I believe the reliability, the accuracy, and also patients get to see their information from provider to provider, and oftentimes have to correct some of the information, particularly around their medications. And so they become actively engaged as well.
I'll expand on what Marjorie just said regarding 13 electronic health record systems. If I show you 13 puzzle pieces, it's going to be challenging to see that final picture. But to have that one record and show you that one photograph of the person we're caring for, it's much easier to see it from that one record as opposed to 13 different pieces. I think in terms of reliability, that's paramount as an Epic hub, and together working with our Community Connect partners, with UBMD and ECMC, that is something which we want to focus on from a technological perspective and to have that uptime.
That's a great point, and this is probably for Asim or you, but the old data. So I have had so many whatever, why do I need? And so the old data will be brought over, correct?
Dr. Brashear, you're absolutely correct. So that's really part of what we're looking at today, and we're doing testing on what we call data conversion and bringing over, depending on the data type and depending on some of the limitations that Marjorie actually had just said. Some of the electronic health record systems have been configured in a way that does not necessarily allow us to bring information over. but we want to work on bringing at least 3 and sometimes up to 10 years of data to the new system.
Excellent point.
If I can add to that, um, again, this transformative change requires a resource that's going to make sure it's done, that it's done right, and that it's sustainable. And so significant resource on the back end has been put into place to test, retest, and test again to ensure that whatever data is crossed over, that we have accuracy. And then ongoing, there's a process that's been put in place to ensure that we're making sure our data is accurate, because this is health information.
And awesome. In your other experiences about bringing the data over and the storage and all of those things, that's all part of the process that people have done many, many times over.
Yeah. Yeah, I think so. So I think so. It's a very delicate, journey. So obviously, to my colleague's point, I think so. Part of the conversion, you have to bring the legacy data 5 years, 10 years, depending its demographics, allergies, medications, and so forth. So, yeah, we'll do our best to bring as much as data we can in the system. Some of the documents will be scanned in, the revenue information would be there, and obviously the clinical information would be there. But then there is, the question that probably I have solved myself and I've shared with my colleagues is like, what happens with all that data that is out there, So would we just shut off the servers and burn the data? And no, it's so I think so that's where I'll I'll pull up my CDIO hat and I'll say that's a asset, that data is an asset. So yes, most of the data will be in Epic, but let's try to make use of that data that it is there. So at that point, I think so we can think about the data lakes of the future, where we have Epic and ongoing Epic data and whatever we were able to bring it from the legacy systems, but also be able to create those data lakes where we can bring this Epic and ongoing data into a data lake as well as that legacy data that is out there for many, many years. Back then at AGH, we went back 80 years of data was there, with multiple, EMRs that went through. So why don't you can take that use of that, decades worth of data out there, which is part of the same patient cohort of the same geographical area. So bring that up, and use them to be in those data lakes. And it can serve two options. One is obviously the legal thing that we have to solve for. So we have to keep the data for 7 good years to just make sure that the legal things are taken care of, and then also use that data along with Epic and ongoing data to build those data lakes, which my research partners will be very much appreciative of. If you can bring that into such a certain kind of a schema that you can put queries on it, and then you just have right there 100 years worth of data for researchers to use that.
So you used the term data lakes, and I'm not sure, I just want to level set with the people. There's a variety of experiences here.
Yeah.
Can you just share a little bit of what?
Yeah, that's the dilemma of our technical people. As much as I try to hold myself of not using Greek, but if the physician starts speaking, I'm going to be okay. Yeah. No, so think about, so a data lake is just, and this is just a word by itself. Technologically, it might say something else, but all you are saying is you're trying to bring the data from different sources, and it's easy to land it in a place that does not need a lot of build work. In the previous years we used to build data warehouses one at a time, and then it was very hard for us. But with new technologies in cloud, with Amazon, with Microsoft, and all Googles of the world, they have brought these data lakes where with that data pipelines can be built very easily. It's very fast. You can ingest data from multiple sources and it will go and lay it for you. So it just takes away a lot of that upfront build work that the developers used to do for many, many years and weeks. So it's just fast tracking, bringing all the data from different sources and stage them in a way that you can use them. I think that's the easiest explanation of it.
Sounds good. Yeah.
Thank you.
Anybody else on that comment topic? So the next one is to Heather. So we want to talk a little bit about the balanced outcomes and impact at scale. So, how do we think that having one health record will close some of our gaps across certain populations?
Sure. I think that's a really one of the great promises of this a single record, this longitudinal record. It brings together medical data, behavioral data, and data on the social determinants of health in order to identify really what's going on holistically for each patient. It also allows providers to identify care gaps. So if people have missed screenings, or if somebody is at risk for developing some kind of disease complication. And then, like was just discussed, we can stratify by demographic characteristic in order to really pinpoint what is going on and put resources to issues that are identified. It also gives the option or opportunity of real-time outreach. So the system will alert providers when something has been missed appointments, needed follow-ups, patients that have high risk scores for different things, and proactively reach out either via text or phone, or the patient portal, the HR, the record itself. So it really kind of mitigates any problems before they really become truly problematic. And then finally, these connected records can identify population level issues. So in aggregate, the data will allow for the identification of particular communities or neighborhoods or areas that really need directed resources.
Go ahead.
Just to add to that, just from a simplicity standpoint, think about a provider, primary care, or a healthcare worker, a nurse in a hospital, social worker that has a newly diagnosed diabetic patient. And in the office, the primary care provider had identified that this patient suffers from food insecurity. You have that information now at your hand. You also have community partners. We know the CBOs that does, we're going to plan and teach this individual how to eat safely, right? And so knowing that is important. Knowing your population that you have is important. Telling me eating something that is foreign to me, particularly if that's not culturally sensitive, I am not going to eat it. I will not tell you I'm not going to eat. I'm just not going to. But think about how powerful that is to have that information at your fingertip. So then connect. We have with this one singular platform, we then will connect with community partners who may be the most culturally appropriate and linguistically appropriate to carry on that diabetic teaching, because the end goal is to get this person to participate in their healthcare and be healthy. So just having not just the information that they are food insecure, but who in the community, which community partners can be the right place, the next place to send that individual to continue their care. This is what this allows in a much more streamlined way.
Others?
I think what I am excited about, as Marjorie also had said, how do we engage those community partners? And having a web portal we're planning to stand up that will allow them to follow people who they want to interact with. So we have the right guardrails in place in terms of our patient privacy, but at the same time, we can transfer that right amount of information at the right time to the right place will allow us to get there from that web portal as well. It will call Epicare Link.
I think also one of the pieces with the community partners, so the UB Health Equity Research Institute collaborates with, I think there's 12 or something, 14 partners. I think there's really a chance to develop a deeper synergy because the patients can then plug in and you can do much more directed teaching and patient education, and it's electronic. And I mean, there's a lot of ways to do that. I would also say we'd be remiss if we didn't talk about the research angle here. So, perhaps someone can speak a bit about how you can recruit people into clinical trials. So if you're in a clinical trial, you oftentimes are seeing the physician or their team very frequently. And oftentimes there's improved access to care and improved care. And so the ability to recruit people into clinical trials and have pop-ups and, newly diagnosed diabetic who would be able to be available. And as the research partner with UB, we're really interested in expanding our clinical trial footprint. So I don't know if somebody, one of you two, want to say something about how that works, how that's operationalized?
Yeah, I think so. This is very important. So a lot of these tools that for example, the pharma companies use, for example, Trinetics is an good example, how you recruit patients. So I think so with with having Epic on board and having that federated data available, I think so these tools that are used for federated research becomes way more easier. As we go on Epic, Cosmos is their federated data source. Where we have like many organizations becoming part of the Cosmos. Again, it's a federated research data repository that provides de-identified data access to all the partners, and they can run queries and then get and
Across
then
the country. So
across the country.
Cosmos is
Yeah.
like
It's a country.
the data lake
Yeah, yeah.
on
Of
steroids.
all the Epic customers who have agreed to participate in the program. Trinetics is another tool that I've used in my previous organization. Again, a similar, a pharma-based technological platform that again works with physicians, all these health organizations, and recruit them and use their data in a de-identified manner, and they run their queries, and once they find a particular subject that they want to recruit, and that's where the collaborations and HIPAA compliant way that gets. So I think so the opportunity for us is, as we go on Epic, it will be way more easier to federate that data. We have that available in a de-identified manner for federated data research, and easily be available to reach out. We have to build that reverse mechanism of taking that patient which was in a de-identified manner and be able to reverse engineer to get to the actual patient, provided all the IRB and everything else has been taken care of. So that's how I have experienced in my past life.
Maybe just to add to that as well is certainly from a clinician standpoint, if I have a patient who may qualify for a trial, that's one way how that's going to be simplified, and it's going to be much more transparent to work with one system as opposed to 13 different electronic health record applications. From a patient's perspective, having that one patient portal through which I can actually see what's available for me if I have nuance of diabetes and what is it that people have out there that I could participate in. That's another opportunity. But I'm also going to highlight the fact that, that Dr. Khan had said, Cosmos as a platform through Epic allows clinicians to look for other patients who they may not have seen in the past. Epic calls them lookalikes. And this is a powerful tool where if someone is presenting to the emergency department or to primary care, and that physician may not actually have that expertise at that very moment, Epic will allow them to reach out to others across the country to collaborate and provide the best care for that patient.
I think it also doesn't lean towards learning. So if you are in another place, I believe they can reach out and say, I've got this patient on X drug. Has anybody seen this? And from an FDA perspective, there's, after approval monitoring, and a lot of those things are discovered because of the networks of people who say, I saw somebody with this, I saw somebody with this, and, this could either be a potential treatment or a potential side effect, et cetera, right? That's also part of what the opportunity is.
Yes, and I think that's really going to be something that we can leverage and improve the health of our community.
Yeah, absolutely.
And if I can add, part of what Epic does is, as I said, improving communication. It allows patients to better engage in their care. Part of that engagement is developing health literacy, and we do know that there's a lack of trust in our system around research. And so, the better engaged a patient population becomes, the more literate they become around their health, it improves the chances of them accepting and being involved in health studies or research, because then they start understanding and seeing the value of it. So it comes full circle, that improving health literacy.
Excellent point. And also helps in terms of the people who are due for, colonoscopies and mammograms and all of this, right? In the current environment, we all have to remember, it's like Post-its all over. And you now have those messages coming and being pushed out that you're due for this and that. And as I am ideally move from fee to service for more of a value-based payment model, those outcomes are incredibly important for patients, but also to make that system work, right? Kristen, did you have some experience with those ways we reach out to patients?
Having campaigns, and so when we think about how do you engage patients, yes, probably many people, if not all, will have some sort of a smart device, either in a pocket or in a bag. But we have to acknowledge those, as Marjorie had said, who may not have all the resources. They may still have the old flip phone. And so we are going to be leveraging also SMS-based campaigns or messages of how do you remind people, give them nudges, you're due for the appointment with your primary care physician, or you're due for your lipid panel. And so I think that's going to be important as well, looking at us, how we can better empower people we serve with guided scheduling so that they will get a nudge that you are referred to cardiology and these are your options to schedule an appointment. That is going to be another tool that we would like to utilize.
So let's talk a little bit about the two letters that I think is every day in our lives now, AI. So we know that behind the scenes, Epic has AI in the background. I have a computer scientist here to answer this question. How do we know, and how do the clinicians still have some leverage on that? Tell me a little bit about how that works and what we're doing to make sure that the patients are still, having their data looked at, all that stuff.
Yeah, so the AI itself is very interesting. There's a lot of hype around AI. Then it also has some of the fears of AI. So I think so. The truth is somewhere in the mix. So the AI itself is not new. The term is there for decades now. We all who are worked in computer science, what we used to call them advanced analytics. We build predictive models, that will, take your old data and we will train that data. And based on the historical data, it will, tell us what the most probable outcomes are of that particular scenario. And then we'll take, a small set of data and then we'll pitch it against the production data and see, as we develop those models, how they are doing well in the real life, and then we'll see, okay, what's the gap between the test data and what's the gap, how it looks when our algorithm runs. So that will tell us how accurate the model is. So those models have existed for years and years, and our experience has been, there has been more success when those models were used in like, helping the workforce, for example, in appointments and scheduling of the ward, and revenue cycle and clinical access. So those models have really worked there because there is not a big concern about physician doing something wrong with their patients. So I have really struggled to sell those white papers from Epic, where it's, this is going to help with your stroke risk analysis, with sepsis, with and so on and so forth. I'm thinking about all those days where I was asked in front of a physician, okay, go and explain this white paper, and I said, okay, well, I need Epic here. So I think so. And then this AI, and when we say AI, the generative AI. So the Gen AI is the next step of that predictive models that we used to produce in years back, where now it can take the same information and come up with something new. And it can come up with something new that again is very exciting. So again, I think so. There are two aspects to it. There will be a lot of excitement around the tools that this Gen AI provides physicians to help make their lives easier, to bring joy to their physician practices, bring joy to physicians with the relationship between physicians and their patients. So when a patient is in front of their physician and encounter the physician is just talking to their patient, and they're not looking at the screens trying to put those notes. So those Gen AI models, either from Epic or some of the ambient technologies that are available through our vendors, are going to help physicians to bring joy to their practice. So that has been a huge hit. Similarly, those kind of other tools in Gen AI world that has helped with denial management, revenue cycle management, bring finances to a better, that have been a huge hit, because again, there is not a clinical risk to it. All you're trying to do is, okay, this work used to take 15 people to do that. 15 people used to go to 20 different places to pull that information from patient chart, bring that into a template and send that to a denial agency to appeal for that denial. So those use cases have been a great hit. I think so. The challenge or the risk would be, again, when we are talking about real clinical use cases, where physicians, they will get the information from Gen AI, they'll get the information from AI, but they think so they'll think twice and thrice to go and take that information and make a determination. And I think so that makes me feel better.
That's helpful. Did you want to add?
Yeah, physician.
Dr. Khan is correct. So when we look at research that had looked at how does ambient scribing or ambient listening technology support a clinician's day-to-day practice, and actually now nursing as well, we see efficiencies gained, and we see that what we would call the burden of finding information, looking for that needle in the haystack of the electronic health record system, that cognitive burden is really high. It's not necessarily just opening up a word processor and navigating and changing things as an application. It's not necessarily your iPhone or Android, but the electronic health record system is in fact quite complex. And so if you take that out of the equation and then you introduce an ambient scribe technology that can essentially transcribe the conversation with the patient, and at the same time, hopefully queue up some orders, that is life-changing. At the same time, I would like to highlight other opportunities that would help us not only with patient safety and data accuracy, and one of them is chart synopsis. So imagine you are the physician who is being consulted on a patient that has been seeing specialists now for the past few years, or it's a patient who's been in a hospital for several days and you need to get familiar what had happened. And I think that's where the power of large language models can come. We do have the important task that AI has to be ethical, transparent, and secure, so that we trust the information, that if I ask that tool to do a chart synopsis for me, then I will get the pertinent information on that. And then similarly, have a chart summary. We often struggle with discharge summaries to be completed on time. Perhaps you're, yeah, sometimes. And maybe you're that person who's discharging the patient, and that's your day, but they've been in the hospital for the past month. But yet you are the one who are to summarize everything for that final day. That's where the tools can really shine.
Yeah, that's great. Yes, because I'm sure we'll have many happy physicians.
We hope so.
So can we talk about who knows what pajama time is? Yes, I see a hand up. Yes, very much so. Okay. So I hear there's a promise of decreasing pajama time. Anybody want to give some insights into what I'm talking about? Okay.
Burnout for not just physicians, but again, nurses, advanced practice providers is real. And electronic health records have been cited in many sources as an important part of that burnout. And what Dr. Brashear is referring to, that the time we spend on charting after regular office hours, so think of the physician who finishes seeing their patients at 5 or 5:30 p.m., goes home, takes care of family, and then at 8 p.m. logs in to start doing his or her charts. That's what we would be referring to as pajama time. The tools that will be at our fingertips will be able to use a dashboard called Signal, in which we are able to then pinpoint and find our colleagues who are struggling. And then from medical informatics, we're able to reach out to them and offer help, offer efficiency tips. This had worked for many health systems, University of Colorado, University of Pennsylvania, what have you, where you can do sprint sessions and you're able to elevate someone's electronic health record knowledge or efficiency and decrease that cognitive burden and essentially improve their or lessen their time they spend outside of office hours.
That's excellent. Yes. So we, want to make sure crystal clear that this is not about increasing burden of providers and staff. It is about decreasing that burden and improving patient access, lowering cost of care, and that just it's really important. And I also think I'd love maybe Asim or Marjorie or Kristian to talk a little bit about the depth of training. So, we are committed to training. The dean will be doing training. Everybody will be doing training. I do clinic a half day a month with the residents over in the conventions building, and I am so looking forward to Epic because I came from 2 Epic shops at Wake and at UC Davis. And, Allscripts is not quite Epic. They try, but and so the training too, and while the training may sound like, oh my gosh, I've done EMRs. If you don't do the training, you're just not going to get the benefit. And of course, if you don't do the training, you're not going to get to use the system no matter who you are, even if you're the dean. And so everybody's going to have to do their training at the appropriate time in terms of the go live and when you're going to be interfacing with a system. So could you, somebody say a little bit about the at your elbow or the training and how important that is?
I'm not going to beat around the bush. Training is a heavy lift. What I would like to acknowledge is that the hours we spend training up front are many more hours we will save ourselves from frustration, from inefficiency. And the earlier we learn the system, the better we'll come out on the other end. And think about it from a perspective like driver ed. You certainly could learn how to drive a car. Not sure you want to learn it from me. But if you go to a driver's school, and that's time that you have to invest, that's the extra resources you have to invest. But I think that the person who comes out from driver ed will be a safer driver, and they'll be more confident of using that vehicle, and they'll be better at it.
No, I think so. I fully agree what you said. I think so. What is important is when we go on Epic, we are just not buying a system. It's not going to be a one-time investment. It's an ongoing process. It's a living and breathing entity that we are bringing in our system. That what that means is after 3 months we'll be having an upgrade. After 6 months we'll be working something we call staying current. After 8 months we'll be working towards our gold stars, and so on and so forth. And Epic keeps us on the toes all the time. And myself and my colleagues from Kaleida will be working on it around the clock to making sure we are bringing as much as current utilities from Epic. While we are speaking, Epic is already developing for next 5 years, and we hear about those things when we are on UGMs and XGMs, and the great minds over there are working from the inputs of the community. Like our leaders, like Dean Bashir, when they go on XGM and UGMs, they share what physicians are asking for, what patients are looking for, what our health workers and how what our nurses are looking from the system. So they'll take all those information, those inputs, and they'll bring that through the channels, and they'll develop those magnificent tools that then we will have to adapt over the years. So training is not a one-time job. It's not only an upfront. Yes, they will be training the physicians, but it's an ongoing process. So we will have to have those teams available that will train the physicians and clinicians upfront, but also as we go through this process we have either in the form of nursing informaticists. The CI teams are very important in decoding the workflows and bringing those workflow challenges to the analysts on the IT side, and then the IT side works with Epic to build those into workflows. So that transformation and translation of workflows from idea to a workflow and to the application build is very important, also part of the training. And then the normal training, what we call the IDs, the institutional designers who help build those workflows throughout the process. So I think so training is an ongoing process. It will be a living and breathing commitment that we will be doing to help our physicians and clinicians to understand the system better, get that information back, and implement those changes in the system and give it back to the physicians for them to take the advantage of the system.
Yeah, and if I may add, besides training, there will be prior to go live workspace where you can actually go in, and it's highly recommended as best practice where you
Sandbox. Yeah.
where you actually physicians can customize. And so you start just like we do now. You have your order sets, you tweak them, you customize them a bit, make sure how you experience the when you log in. Your experience is unique. If it's what you want, if you want things on the right and the left and the bottom to the side, what order. And so that's highly recommended because that will make that implementation go smoother. We will have side-by-side, elbow-to-elbow support for about a month after go live, which is crucial because we all know sometimes when you learn, you think you remember until you have to do it. And then you realize, oops, I forgot. So there will be significant support built in as well. But that ongoing training, I really recommend just that mindset that there's just going to always be updates. And so training. I've been involved into Epic implementation in my life. And yes, we know physicians get trained, but I will tell you, they look to the nurses on the floor when they show up on the floor at 3 a.m. and say, what was I supposed to do? And so we will have a lot of super users, but the more you can familiarize yourself with the system and do the customization, it actually makes it easier at implementation. And then we'll work through any glitches. We're good at that.
So I'd be remiss if I didn't mention our learners. So the Jacob School of Medicine and the University of Buffalo is committed to transforming the health of Western New York. And one of the ways we do that is by training the next generation of physicians and providers. And so right now, our medical students go from system to system to system, and so they have also multiple passwords and multiple systems to use. Our residents go from ECMC to Oshai, Suburban, Kaleida, the VA, Roswell. Some go over to the Catholic system. So again, you can just imagine how many different systems I just mentioned, and in an outpatient. And sometimes they can go to one clinic inside the medical school, and the 6 of them are on all scripts, but some of them are on something else. And so from a learner perspective, that's a big issue. And so one of the things is not only are we talking about the patients, we're talking about research, we're talking about community, access to care, cost of care, all of that, cutting edge, getting into clinical trials. But we're also talking about making this a place where someone can see themselves growing roots and staying here. So we would very much like people to go to the medical school here, do their residency here, and stay and practice here. And it's a lot more friendly when they go, they're not having to relearn a system every time. And that, I think, is one thing that is missed. We want to be not just patient friendly, but we want to be provider friendly and nurse friendly. And we want, again, UB has 12 schools and 6 are in health. So University of Buffalo was founded by the medical school in 1846. So grounded in the here with the medical school, but then we have nursing, dentistry, pharmacy, social work, and public health in the medical school. So that's 6. And so that's really important because we want them all to turn out students who will then stay and work with our health partners. Moreover, the medical school trains, people who work in the lab. So we have, laboratory science degrees, nuclear medicine degrees, all for the undergrad students who we would very much want to stay. So this is more than just about doctors and patients. It's about making sure that we have a pipeline of individuals who want to stay and grow roots in our community. So I think that's a piece that we oftentimes don't talk about, is the education piece and making sure that this is a place that is really welcoming for the future. So have you seen that in the places you've been?
Brashear, I think that's also a very important question. How do we support our medical students and other students on this journey? And certainly from a training perspective, that is something which we would like to find a way as well, so they can participate in this. We've been working with our graduate medical education office, and we need to engage with our undergraduate medical education office as well, so that we are able to identify and essentially help people to learn the system. Some of our residents already know EPIC because they perhaps have used it in other institutions. What we have been working on is if someone had been working with EPIC in the past 12 months, they had the opportunity to test out. And we'll look at that in the future as well. So after the go live, when we have some colleagues who actually come to us and they may have used EPIC in another institution, how they can test out, so then we can then take them to the user settings labs, as Marjorie had said, to help them customize the system so that it works for them.
I think the more we can do to have a really welcoming environment, we want, we want people to grow. So it's incumbent upon all of us in Western New York to have more people stay and grow roots here and raise their families here. And one of the things that you can do from an economic development perspective, and you probably have, is you can use healthcare in 2 ways as economic development tools. One, hire more doctors and more providers and more nurses and, all of that, and bring in more grants and more clinical trials and all of that piece. And that's great. That's very, very important. But the second piece is to make sure that you have health systems and almost always associated with an academic health system with a medical school, that is really important because then you have the community to be healthy. And if you are, Amazon or whatever, looking for the next place, they want to go where there's going to be great health care. And so the 2 pillars I just talked about interface to making Buffalo and Western New York be much, much more robust. So we want to keep the businesses that we have, but we want to bring in new ones. And so And likewise, if you think about places that you want to retire, right? People look for good healthcare. So good healthcare and a good, healthy workforce, all these things are win-wins. And by being able to have the improved access to care, lower cost of care, all of that stuff, it's a really an economic development engine in addition to all the nuts and bolts that we've talked about. So does that sound, I mean, I'd love some comments from the group. Yay.
Actually, just bless my heart when you talked about economic development, because, you know, healthcare typically is one of the largest employer
Oh, yes,
in
absolutely.
in most communities, and so keeping so not just employing but actually good paying jobs, not just employing entry level but all the way from entry to terminal levels. And so having strong healthcare system, robust healthcare system, and I believe having a single EHR with Epic helps to support that. It actually brings new talent into the market. People are being trained in things, ways that they probably would have had to leave to go get this experience. So just having the economic development again goes back to that, you know, freeing people so that they can afford to eat properly, they can afford to live properly, they can afford to manage their stress and anxiety, addressing behavioral health so that they can be good, healthy citizens. It does again attract people in. So you just said that so perfectly. I hated to add to it, except that it's such a passion of mine. I just wanted to echo what you're saying. And also one of the things that we found we started looking at is we are now taking in people straight out of high school into some of our entry level positions. So not only they are our population as well, they use our healthcare system. And so in order to, if we're doing this for patients, we can also do this for our employees. They live in this community. They have many, many generations. They're not going anywhere. So that's beautiful to be able to live, grow up, work, thrive, and remain healthy. It's really a goal, and I see this Epic launch as just a, if you know, and it will not if it will be done successfully, will be a catalyst for that.
Yeah, a catalyst to continue to grow Buffalo across all areas. And I think that's the piece, as someone who's now lived in the city for 3.5 years, there is such a passion for taking Buffalo to the next level. And the fact that we will have this as a very large footprint, I think will be, as Tim Murphy said, we love Tim Murphy, a game changer for everything, for research, for education, for the community, for access to care, for health equity. So how do you think we can message some of the conversation we've had here today to the clinicians so that, you know, we begin to say, this is just incredible opportunity. You've been in other environments. What do you think?
I think we need to meet the clinicians where they are and get them involved in the system early on so that we can see and they can see their own fingerprints on the system. We call that specialty review sessions. We've been engaging our subject matter experts that have been selected by chiefs of service so that, yes, we are taking foundation system from Epic, which is a collation of knowledge from about 300 different health systems. And at the same time, we are seeking input from our subject matter experts and our colleagues early on. We talked about training. I think getting people to training, which will start for our super users at the end of February, and then our everybody else in March of next year, will be an opportunity not just to experience the system, but also to get access to our what we call play environment. Dr. Khan had said our sandbox, in which we would encourage people to go back and maintain the skills that they had learned. We don't want necessarily the training to start very early on because then people could forget. At the same time, that play environment will allow them to go back and do perhaps shadow charting or other activities that will allow them to be comfortable with the system, and we go live in our first wave on May 30th next year.
Yeah, just probably a quick comment, and again, coming from the IT side of as we go live with Epic, I think so. From my 15 years being in Epic shop and going live with multiple waves and cutovers, I think so. The lessons that I've learned and the experiences I've is from physicians' perspective is the physicians need to know that it's a change. It's a change management process that we, along with the whole IT plus the physicians and clinicians, have to go together. So I have seen, to be honest, physicians getting panicked at the night of go live and not liking the thing that they used to be doing it back then with Cerner and others. And so I think so that's where I think so. It's the technology, the training, everything has its own place. But I think so. The fluid side is the change management. Part of what we will be doing on the technological side, I think so. We have to work with our physician clinicians to be ready for that change. Most of the physicians might not like what they're doing on the first day. You know, they might not find, to your point, where things are, where the button was, or where the click was, or they are doing more clicks or less clicks for doing certain things. So I think so. Together with your leadership in Brashear, I think so. That's the message about. Okay, I can take care of the IT side, but yeah, yeah, I will take that. But yeah, but I think so. The message about the change management, the change is important. You know, so we have to be patient through the process, so we can serve our patients better.
So I think from a change management perspective, there's this whole thing about creating a sense of urgency. We've created the sense of urgency here, right? The sense of urgency was created, and we all jumped in and made a commitment, a significant financial commitment of time, treasure, resources, person power, et cetera. So we've created that sense of urgency. We need to create kind of the community of the willing. And I think that's part of what we're doing here today is to create that community that's going to carry that message, whether it's to, the surgeons who probably aren't going to want to sit down at the whatever many hours of training, or the neurologists or anybody, or, we're going to have a lot of that. And then we're also going to have some community members that get spooked. And so we really want to invest in that community. And this is the beginning that message and having you be part of that community. So I think and then we have adoption, and then it just becomes part of your life. And I just know that in my past experience, everybody who went to this type of really up-to-date electronic health record, whether it was Epic or another brand, it was really, to quote Dr. Murphy again, a game changer. So I think that's one of the things that we want everybody to really begin to talk about. Can we shift gears a second, and can we talk a little bit about governance and ethical data use? And I'd like to hear from each of you about how we begin to think about data governance and decisions about data, and also about the ethical use of data. So I'll start with Asim and go down.
Yeah, sure. I think so. It's a very important and very delicate subject, and I think so. It can lead to enormous successes, and it can lead us in troubles as well. So let me say it this way. But I think so. We need to understand what is governance. Specifically in terms of data and healthcare environment. So if you would ask me many years ago what governance was, I would really say it's the implementation of compliance. So you just take it from the compliance yardstick and say either you are compliant or you're not compliant. So that's how I used to take governance. But over the years, I think so. I have changed my definition of governance is from compliance to building trust. Now, what is building trust? So who are we dealing with? Who are our stakeholders? So our stakeholders are patients in this community. We just talked about Buffalo and how, and coming from Pittsburgh, I think so I've seen the change there as well with healthcare booming. So I think so the building the trust is the first thing that we have to deal with. And so if I'm a patient and I'm a member of this community and I cannot understand or I do not have the trust of how my information will be used, the best of the best of innovation and the technology that we bring in, they will not cherish. So I think so that's the first thing that we have to realize together is to build the trust between us and patients and the communities so that they know that their information and their data will be used to benefit them ultimately. So that's the first thing, and that's the message. I'm talking about Epic, and I think so the term that I used to love to use is when we bring Epic and we talked about a single patient longitudinal record, what that means, it's going to federate the data. What that means, federation of data, is mean previously in different other EMR systems which were not centralized versus the centralized EMR that Epic is, it will bring your revenue information, it will bring your claims information, it will bring your clinical information, it will bring your access information, it will bring your financial information all in one place. So if I drain that through from the top to bottom, all the data will come in one place that we can use. So what that means is we are federating the data upfront, but the benefits of that would be we would be democratizing the data downstream. What that means, so we democratize the data so we can take the data and then we are easily slice and dice the data and we can give it to the users to use that data, either to physicians and clinicians who can get more real-time reports on what's happening in their clinics, but also the data can be used for building those analytical models that we talked about. We can build trends, we can build dashboards, we can build other visualizations on top of that, and the same data can be used to build AI. But what this means is brings a huge responsibility on us again to make sure as we democratize the data, we are making sure that we are compliant as well as HIPAA compliant and all that stuff. The second thing I think so is once we have understood what governance means for data governance in healthcare, I think so the next thing is what are the best frameworks for that. So I think so the first framework is again comes from the workflows, the clinical workflows themselves, where we are building a dynamic a dynamic framework of consent, what that means and how I understood that. So to me, that dynamic consent framework is a living and breathing workflow where we are not asking patients to go and fill a form and get done by it. So what that means is when we go and implement Epic, our patients are approaching the welcome kiosks. We are asking them, hey, do you want to, do you are going to make a consent of, sharing your information or not sharing your information? So we should be able to give those tools to our patients who can on their own go and update their consent and say, I want to be my information to be interoperable or not. We should be able to build those registries in the back end in Epic to, hold that information that is not shareable along with, sensitive behaviors and all that kind of diagnosis, ICD-9s and ICD-10s. So I think so building that workflow mechanism of an ongoing consent framework, that would be a key to keep the governance. And then we go into some of the other details like, we have to be transparent with our customers and our stakeholders and our patients. What does transparency mean? So transparency means, in my ways, is to not putting a computer science hat or not being a physician, but in a very plain language, we should be able to explain to our patients how that information will be used, who will be using that information, who has access to that information, and ultimately sharing the benefits of sharing that information. As we just talked in the beginning of interoperability, they don't have to take their information from one place to another. It's going to be automatically flowing into the system that they're going to see next, as well as the same information will help to better off the healthcare moving forward. So I think so that's the transparency, how I see, is to be very robust and plain in language, explaining the benefits of data to our patients. The second thing is the accountability. I think so the accountability is on us, That's where we talk about the data governance frameworks. That's where we talk about building those stewardship, councils that includes physicians, that includes researchers, that includes technologists like ourselves, and then it also includes patients or patient representatives to create those stewardship councils that can weigh into a technology and say, is this good, is this not good, how it's going to help or not. So again, building that data governance mechanism where we have an executive steering committee, where we have defined data stewards, where we have defined patient data owners, and then we have this mechanism of taking these new innovative ideas and parse it through those stewardship committees and come up with a positive or a negative approach. Now, coming to a little bit of a technological thing on it, what are the frameworks that help us most? So again, I'm a big fan of federated data networks. That was my PhD in healthcare. So, so that's has been my passion. So I think so. What that means is when you are dealing with a federated data repository, it's more HIPAA compliant. So you're not moving raw patient data from one system to another, and it's not going back and forth. Rather, the access based on the right access and the roles defined. The data is still there, and people come and access the data that they need based on what is the use case, and so that's the transparency and accountability that we have to build in. And I think so the federated data models help that the best. And then obviously technologically we have firewalls, the HIPAA firewalls in between the page, the data movement. If we are going to the cloud technologies, they're all high trust compliant. When the data is out there, they're all safe and sound in their own areas. And I think so it's the relation between governance and innovation is very sensitive. We should not take governance as a barrier to innovation. It should be taken as an enabler of innovation. So as the relationship is sensitive, but again, I think so we should use data governance and data governance frameworks, and there are multiple of them. We will be using one of them, or we'll be taking some of the industry, like IBM has its own maturity model. The Data Governance Institute has its own framework of data governance. Gartner has one, and I think so in my past experience, we have taken those and we have tweaked it, and we have came up with our own, compliance and data governance model. So again, I think so if we can build that kind of a framework where it provides access to data, it provides the right access to the right people at the right time, we should be able to build that ecosystem where we can use the data in a compliant manner to do the innovation of the next level. Thank you.
Just pass the mic down.
We are connected for change. I'm really proud of UBMD, ECMC, Kaleida Health coming together and essentially standing up the scaffolding that we call our governance around how the technology will be implemented. And we stood that scaffolding of governance up on the foundation of trust. And I think that's really crucial for us to serve our community.
I completely agree. Trust is going to be the cornerstone of all of this. So I really am a strong advocate of co-design to the extent that we're able to include community and patient voices in development of data sharing agreements, the consent processes, and even the governance structures. I think would benefit immensely by taking that kind of an approach, and especially for populations who have historically been disenfranchised and treated, suboptimally. So I really think that in order to get the trust, we need to involve the community.
Great point. Great point.
The only thing I'd like to add is just from a practical standpoint, UB has a strong history in research, and so understands a thing or two about ethics and how appropriate use of data. EPIC allows more data to be available at the end user in their hands. And so it has a module called Slicer Dicer, where now information can be easily extracted. And so that's something that we would, we need to pay attention to. What safeguards do we put in place? What auditing and tracking mechanisms do we have in place to ensure all of our organizations have lots of learners, lots of curious minds? And so curiosity, sometimes people do well-intentioned things with information that no harm intended, but was it an ethical use? And then in terms of ethics, as a healthcare worker, a provider, I always wonder, why do we collect the data we do? And how do we get to a point where we collect absolutely what's necessary, no more, no less? Because we are federating very private information about people. And so while there are HIPAA laws, now with Epic, we're going to have the opportunity for individuals to potentially print off information, print off a report. Not as concerned about de-identifying because they're not going through an IRB process. So all of those things which should come through a governance structure and make decisions around those and be proactively or laser focused on preventing data breaches as well as cyber attacks. Because that is out there. And so we need to, even now more than ever, with one health record connecting all of our system, be laser focused on preventing a breach in that system.
That's an excellent point. So what I'd like to do is now open it up to the audience to ask questions. And Dr. Cizek is going to help us moderate. And I want to thank the panelists, and hopefully we will have some robust questions from the group here. And please, when you ask a question, stand and give your name and where you're from, and we will do our best to answer. Yes, sir, in the back.
So good afternoon, everyone. I'm one of the clinical informatics fellows here at UV. I had a couple of questions regarding security and compliance. What are your top concerns regarding cybersecurity and data privacy? How do you prepare these systems for increasing threats like ransomware? And how do you ensure compliance while also, as it was mentioned earlier, this is kind of a growing live system. So this isn't kind of a one-stop shop that we're kind of moving and transitioning to. So how do we maintain compliance while also evolving over time?
Great question.
Thank you for that. It's a really great question, and a big shout out to Clinical Informatics Fellowship programs, and a very strong one here at UB. Thank you for that. When you look at cyber attacks, ransomware, and phishing and other malicious activities, very often the culprit is not the electronic health record system. It's the bolt-on systems. And with the project as one Epic, Courtney and the team, what they're doing is reviewing our third-party vendors. And this really gives us the opportunity, not just across Kaleida, ECMC, and UBMD, but also just coming together as a system to review the vendors that we are integrating with, because of the fact that very often that malicious attacks comes from that third-party vendor. And it does not stop there. So I mean, I think that innovation is going to be something that we will continue to see, as Dr. Khan had said, quarterly with Epic. At the same time, we have to remain vigilant to make sure that we have a solid login strategy that we're working on throughout not just the main electronic health record, but the other applications that will be supporting it.
A real quick comment on that. So we'll take care, and I'm sure our leaders are taking care of firewalls and everything we can do technologically to to deter any kind of a breach. I think so. The human factor is the most important, and that's all of us. That will be the key to that. And I know our CISO and CISOs of different organizations are working on that round the clock to do that fake phishing exercises with sending us, okay, so we are not getting trumped by those quick emails that we get or phone calls. So I think so those are the biggest culprits, and it's the responsibility is on us, to just be very aware of those pitfalls that we very much have, patience of not doing that. So I think so it's the training that the CISOs will be flowing, and it's already probably happening. I'm sure it's happening. And with Epping coming in, they will have to be just way more way forward, So we have to be just better trained and keep training ourselves and whoever in the stakeholders are.
Thank you.
Sorry,
Everyone, Alexis Ballinghagen, I sit on the board for the New York State chapter, HIMSS is the president. Quick question, I know we spoke about, having one, EHR platform and a segue to the cybersecurity question. What is your roadmap or strategy for the connectivity of devices and solutions that feed the data into the EHR so that Epic essentially is a robust platform of accurate data?
You want to take a step and I'll.
Unless Marjorie wants to talk about Rover a little. Being in a hot seat here. Mobility is very important for us. And we talked about training and many other areas that we had discussed this afternoon. But that's one of the big benefits for us to stay mobile. That is something which we're not able to do across our 13 different puzzle pieces of electronic health record systems. And so having that robust strategy to allow people, providers, to be able to use their mobile devices to review the chart, enter orders, will come with certain guardrails. And so that's why we rely on multi-factor authentication and other methods, how we actually ensure that the person who is authorized to see the record is truly authorized to do so. And the same thing will apply for our extension that I had mentioned as a web interface to our community partners through Epicare Link. So before they actually are allowed access to the system, they are vetted. We find a person who is responsible for that practice as an administrator. And so then we have a business associate agreement signed with them. So there are multiple checks and balances in place before we actually would allow that either web access or mobile access.
Just add to that, Epic has over 700 installs internationally. And so Epic has a pretty robust vetting process on who they're allowing to log on to. So when you talk about devices, I'm thinking about like IV pumps, blood pressure cuffs, those kinds of things that we're using in a doctor's office in the hospitals. Those, if they're interoperable, part of that, they go through that vetting process to be able to put the information. It's one way, and so it comes into the record. There's always, though, right? Anything can come in, but we never underestimate there's a human factor. So a lot of the things that come in, we also build in the strategies, then you build in that there is a reconciliation by the healthcare worker to make sure, yes, that vital signs was taken, that blood pressure was taken, and the patient wasn't bearing down or, that could cause it to be erroneous. So we go through the vetting process on the front end, and then we teach our staff, if they're going to accept, for instance, a smart note that says, okay, this is what's going on, then you need to look at it, validate it, and make sure it does indeed, you have a responsibility as well. So that's the back end control of it. So and the fact that we're standing on the shoulders of giants, we've had that many installs and successful installs around the globe that we find it's a reliable system.
Other questions? Oh, yes.
Hi, I'm Katya Noyes. I'm Associate Dean for Translational Team Science in the School of Public Health. Thank you all very much for a terrific panel, very insightful and honest opinion about challenges and opportunities. I heard a lot word research been thrown around by all speakers in different contexts. I was wondering if you have a unifying vision of what research along the way of EPIC implementation and use is going to look like, perhaps including translation, teamwork, understanding impact of patient outcomes on access. Would be very interesting for our learners and faculty to start forming perhaps the working groups to support this very important initiative. Thank you.
Okay. Other questions?
Hi,
Hi.
I'm Bridget Bartolone. I work with SNAPCAP, which is a 501c3 collaborative of Article 28 clinics. The common denominator is the primary care safety net providers across our 8 counties of Western New York. 2 of our members of SNAPCAP are ECMC and Kaleida, so we're familiar with what's going on with EPIC, and this has been very informative, so thank you. My question is more pragmatic when it comes to engaging the community, which we've talked quite a bit about, and a community of willingness. There are a couple of, I'll give some examples of FQHCs right here in Erie County, Jericho Road, Evergreen, Neighborhood Health Center. They are part of the SNAPCAP umbrella, but individual organizations, and collectively those 3 organizations probably have 75,000 unduplicated primary care Medicaid patients, okay? So we have a great EPIC system where we're going to have providers, UPMD, CMC, Kaleida, using EPIC. These providers are currently using Medent, Athena, whatever their EMR platform is. So very pragmatically, how do we intend to integrate, especially safety net patients who are high utilizers of healthcare, on a one record system when we're not on that record as a community? And resources are limited, especially in the times of HR1 and finding resources to migrate to EPIC. We love what's going on for the community, but we also have a community around this EPIC community that has shared patients, that have the same needs, but don't have the resources to invest in EPIC. And we're on a different timeline even if we do. So I'd love to hear your perspective on how our providers across the community are going to be engaged in this, because we're willing.
So that's a great question, and one that I think in terms of we'll need to take back to the governance community to unpack. So, but it's a great question, one that has not come up. So thank you for bringing that up. Thank you. Other comments or questions? Thank you. Appreciate
Thank you
that.
so much for doing this, Heather. It's great to see you. So glad you're here. I want to just piggyback in what she was saying about SNAPCAP and social determinants of health. So we've seen this RIP, we've seen the 1115 waiver, we've seen all these social determinants of health being spoken about. Behavioral change, love that you're talking about that. How do we impact the community with lifestyle changes? But how do we capture that data? How do we get that into numbers and into data for the one, and what can we do with that?
Yeah.
Thank you.
Great question. Anybody want to answer that? So we'll take that one back as well. This is really helpful. We've had 2 questions here, and Courtney's going to make sure we keep track of those. One more question, then we have an announcement, and then we need to wrap up. See, who is it? Oh, the yellow. Oh, I'm sorry. Okay. So gentleman here, I'm sorry. I
Yes,
didn't see.
Don Gibson,
Apologize.
Bell Medical, medical device manufacturer in Orchard Park. And I have a question tied into this, and that's Healthy Link.
Yes.
It's an initiative.
Right.
How does this coordinate with what you all are doing with EPIC?
I will just say Healthy Link is excited about this. Healthy Link has a great big region that they take care of, and they're part of the partners. So it's a great win-win for Healthy Link. So I talked to Dan about that and asked him that a couple weeks ago. And the woman, did you have another question? Yes, perfect. Last one.
Just a small comment. Hi, everyone. I'm Shannon Bryant, Chief Diversity and Inclusion Officer with Kaleida Health. We do have a platform called Find Help, which is going to be integrated into EPIC, and that's where all of our social determinants of health, and we'll have some meetings with our community providers
Great.
to make sure they are included in that.
Perfect. Yeah, maybe you can connect and that's perfect. So thank you so much. First of all, thank you to the panel. My understanding is Jennifer Meyer, who is Senior Director of Nursing Informatics at Kaleida, has an announcement.
So first of all, on behalf of the New York State chapter of HIMSS, we certainly appreciate being involved and supportive of the initiative here. And we're pleased to be part of helping coordinate this program and this event. And thank you to all the panelists. This conversation was really, really helpful, and I'm sure everybody appreciated it. My name's Armand, and I am the chair of the membership committee with the New York chapter of HIMSS. And I'm joined by Jen Meyer,
Senior Director of Kaleida Health for Clinical Informatics. We're coming to you to talk to you a little bit about HIMSS, and I brought my expert, Armand.
So real quick, HIMSS is, for those of you that are not aware, is it's a global organization, and you can see the number of individual members and organizations that HIMSS supports. The big number here is 830 million patients are affected by HIMSS analytics. So that's a really big number. Fortunately, Kaleida is a member of our organizational affiliate program, which is a kind of think of it as a corporate member of HIMSS. And some of the benefits real quickly are that it includes unlimited numbers of employees as members. Individuals can log in with their Kaleida email address at the HIMSS.org OA sign up website. And once you create an account, you select the New York chapter as your chapter of choice, and that will bring you into the New York State HIMSS chapter community. And the overall benefits of membership are joining the largest organization supporting healthcare IT professionals. And what that means to each of you is participating in education and networking programs, learning from your peers, and an access to huge libraries of online content specific to healthcare IT. A little bit about the New York chapter. There's a flyer outside in the front as you walked in near the water and iced tea. So I won't go through this, but the New York HIMSS chapter.org website, you can log into that, follow that link, and learn all about HIMSS. The interesting thing is we're 2,300 members strong, and approximately 80% of those members come from the provider community. Some real quick engagement opportunities for New York HIMSS. Participating in local events like this one. Thank you all very much. Some recent other events that you all might be interested in knowing that you missed were an interoperability program in person in New York City, a cybersecurity event which was in person in Albany, an annual clinical informatics symposium in person in New York City, and also in Rochester, New York. So we had dueling communities, which was really great, 2 panels and 2 communities, and it was telecast, and various virtual events covering a variety of topics. And one of the really great opportunities that we talked to Kaleida about, which was the impetus behind coordinating this event, is hosting regional events just like this one. So it's pretty exciting. And we're always looking for people to join our family, join the community by volunteering, joining a committee, and also our mentorship group. So on the flyer out there, and for those of you interested, you can snap that QR code and you can become part of our mentorship community. And Jen is our mentorship task force leader.
I think what's really important here is this is your professional development. This is how you're going to grow in your profession, and it's not just IT. It takes a village to get best patient outcomes. It takes a village to implement Epic, and that includes not only all of these folks up here, it includes a lot of you back there, right? And so being involved and getting and learning everything that you can about your profession and learning what's out there. We can never, when it comes to healthcare IT, it's constantly developing, right? Like you can never be an expert at anything because we've got all these AI things coming out and the next best technology that's coming out. This is a place that you can go and learn about that stuff. So it's really, really important, not only for you, but for everything that we're doing with this project as well, because there's things that you can learn about it.
Thank you.
Thank you,
very
everyone.
much. Thank you. Appreciate that. So in closing, I think this is about, really connected and change. This is change for our community, it's change for research, education, clinical care across all of the enterprises. And we are so appreciative of our panelists here for taking their time and really contributing so much. We're really appreciative of Dr. Cizak and her team and the Kaleida team. And it's really been a great conversation. It is the beginning of many conversations because remember, we want to transform the health of Western New York, and we're going to do that together. Have a great evening. Thank you.